Hello, and thank you for inviting me to participate in your conference. I'm delighted and honored to participate. My only regret is that I cannot be there personally with you to renew acquaintances and friendships, and of course, to make new friends. I'm going to be speaking about perioperative stroke and bringing you up to date on what we know about that topic. My contact information is there on the screen, my email address and my Twitter handle, and you're welcome to use either or both of them. My consulting relationships have no relationship or bearing on this presentation. We did a couple of surveys led by my colleague and friend Alana Flexman of anesthesiologists' knowledge of perioperative stroke and patient knowledge. And here are some of those quite surprising findings. Greater than 50% of our colleagues do not usually discuss stroke, even in high-risk patients. 30% of our colleagues are uncertain about how to care for patients at risk. And patients don't seem to ask about stroke risks either. Almost 90% of them do not. We did a separate survey of patients to try and understand their knowledge, and it was surprising, perhaps, that almost the majority of them, 80%, believe that the risk of dying from a perioperative stroke was rare or very uncommon. Equally surprising is that 3/4 of them, 75%, were satisfied with the information they had received, even though our previous survey had indicated that the vast majority of anesthesiologists do not provide any information to their patients. So let's start with the simple question: is there a problem? Is perioperative stroke a problem? And we immediately run into a problem because we don't know when the perioperative period is. There is no standardized definition that I'm aware of in anesthesia that defines what perioperative is. For the purposes of reporting perioperative stroke, we, on behalf of the Society of Neuroscience in Anesthesia and Critical Care, SNAC, have proposed using the first 30 days after surgery. And this, to a large extent, was influenced by the carotid endarterectomy approach, which is reporting stroke within 30 days of that surgical procedure. The incidence of perioperative stroke is probably somewhere around about 0.4% based on prospective studies. And as is sometimes common, you can see with retrospective studies that the numbers were much smaller. And some of the prospective studies have impressively high incidences. This is obviously influenced to some extent by the type of surgical procedure that is included, much higher in vascular surgery of any sort, for example, than peripheral limb surgery. A perhaps more striking way of looking at it and useful when speaking to patients is rather than in terms of percentages, to put it into numbers. This study, which was a retrospective study, did categorize stroke risk in 3 different surgical procedures and then categorize them or split them up by age. And you can see in low risk or low age, under age 65, perioperative stroke rate, still about 1 in 1,000 in this study. And for patients over the age of 80, about 1 in 500. Those are pretty impressive figures. I also want to introduce you to the concept of covert stroke. An overt stroke is somebody who can't move a limb, for example. That's pretty obvious. But covert stroke is focal stroke lesions that are found on neurologic imaging only, but don't appear to have any clinical features. In the United States, because of the extensive use of CT and MRI scanning, we know that about 18% of the senior population over the age of 60 or 65 have evidence of covert strokes. The Neurovision trial, which was published 2 years ago, was a prospective study of 1,100 patients over the age of 65 having major non-cardiac surgery. And in the immediate post-operative period, they had an MRI using diffusion-weighted imaging, which does allow one to separate old strokes from new strokes. And they found a stunning 7% had new strokes in their head, but no obvious clinical manifestation, although there was an association with delirium and postoperative cognitive decline. So when do perioperative strokes occur? In anesthesia, we tend to agonize about the intraoperative period and think about perioperative stroke as something that occurs intraoperatively. But in fact, only about 10 or 12% of all perioperative strokes are found when the patient awakens in the PACU. The vast majority occur in the first 72 hours postoperatively, and then continue beyond that for a surprisingly long time. This is from a Danish database looking at hip replacement patients, but one can see that the risk of stroke goes out to 3 or 4 months compared to the stroke rate in the age-matched population. Surgery is a risk factor and increases the propensity to stroke. Why is it important? Well, it's not just because it gives me something to talk about. It's of huge importance to patients. This is from data in the Michigan database that we looked at. And you can see that for patients who have a perioperative stroke, only 40% go home. Almost 40% die. And in this study, about 25% went to a chronic care facility. In some other studies in the literature, as many as 50% of patients who survived went to a chronic care facility. The mortality associated with perioperative stroke, 25 to 45%, is actually remarkably similar to the mortality from myocardial infarction. And yet, sadly, we are much, much more focused in anesthesiology on perioperative myocardial infarction and much less focused on perioperative stroke, although in my opinion, suffering a stroke is far more debilitating than suffering a myocardial infarct. Why is the mortality so high? I think there are at least a couple of factors that contribute. One is delayed diagnosis, and the other is delayed treatment. Perioperative stroke is initially a nursing diagnosis. They are the ones who see the patients most frequently. But routine post-op screening for stroke is not part of usual nursing care yet. We know that stroke evokes a systemic inflammatory response, not just in the brain, but throughout the body, and that this contributes to the usual stroke mortality of about 10%. We also know that surgery creates a huge, huge inflammatory response. And as perioperative pharmacologists, it is easy for us to understand the synergistic amplification between these two inflammatory responses, resulting in a significant doubling or tripling of the mortality. Now, a common question is, how long after a stroke should surgery be delayed? And the common answers from many neurologists has been maybe a few weeks, maybe a month. A startling retrospective analysis of a huge database showed that the risk, not surprisingly, continues for much longer. Patients who had a prior stroke have a more than tenfold increase in the odds ratio of having another stroke, and another stroke, second stroke, if it occurs in the perioperative period, has approximately an 80% mortality. Within the first 3 months, you can see a huge, huge increase in stroke risk if surgery is performed. That comes back towards the baseline within 3 to 6 months. So if at all possible, a recommendation would be to delay surgery for 3 to 6 months. Clearly, some surgery, cancer surgery, acute trauma, for example, cannot be delayed that long. Purely elective procedures can, and the literature would suggest should be. Who's at risk? What can we do about it? Well, it's pretty easy to come up with a list of risk factors such as older age, cardiovascular disease, renal disease, diabetes, and so forth, and similarly types of surgery. Unfortunately, there's almost nothing we can do about those risk factors. The surgery is the surgery they need, we hope, and we cannot change their pre-morbid situation substantially. Stroke in general has a fairly simplistic etiology. It's hemodynamic. We often refer to it as hypotensive, the embolic or thrombotic. And in anesthesia, we tend to focus very much on hemodynamic strokes. Finding evidence that hemodynamic derangements, in other words, a low blood pressure, is the cause of perioperative stroke has been exceedingly difficult. This is from a very impressive meta-analysis published just a couple of years ago. The arrow here shows you a mean blood pressure of 60 millimeters, and one can certainly show an association with acute kidney injury, with myocardial infarction, overall mortality, but almost no association with perioperative stroke. We do not have a good single blood pressure indicator that tells us if you go beyond this point, the patient will have a stroke. There's been a lot of interest in beta blockers and the potential that beta blockers may have been the cause of the strokes in the very well-known POISE trial. This is from a retrospective analysis of database in Toronto, the Toronto hospitals, and they looked at all beta blockers. And it looks like metoprolol specifically has the highest probability of postoperative stroke, much higher than bisoprolol or atenolol. And a similar study from Michigan, out of the Michigan database, came to a very similar conclusion. Metoprolol, which does cross the blood-brain barrier more than any of the other common beta blockers, is associated with a higher stroke rate. Of perhaps equal interest from the Toronto study was that as hemoglobin drops, the stroke risk increases, indicating an interplay of some sort between anemia and beta blocker use. So perhaps patients who are chronically on beta blockers, one would want to think about having a higher transfusion threshold. So what level of blood pressure is safe for my patient or your patient? Well, we won't get that answer from big data. Big data will tell us population ranges. It will tell us associated factors, but they won't tell you in this specific patient what the thresholds for blood pressure may be and for management. That guidance ultimately needs to come from more accurate, more refined organ monitoring, where our brains are connected to our patients' brains in ways that allow us to understand the risk that may be occurring for stroke or intraoperative ischemia. There's also some soft evidence that postoperative hypotension may be a much more important factor than intraoperative hypotension. In general, I'd say intraoperatively, even the laziest among us will eventually get up out of our chair and do something about a particularly low blood pressure. The postoperative period, patients may only be seen by the nursing staff every 4 or every 6 hours. That's a long time to be hypotensive. This was data extracted from an ACE study, but is suggestive that the risk is associated with postoperative hypotension, not necessarily with intraoperative hypotension. I don't for a moment want to give you the impression that you should totally ignore intraoperative hypotension. I'm just trying to make the point that intraoperative hypotension is not the most frequent cause of stroke. But that's not to say that it cannot be a cause or that it isn't a modulator. We know absolutely that hypotension will worsen an embolic stroke. And the vast majority of strokes in the perioperative period are thought to be embolic. This is not from a perioperative study. It's from a very, very big study, 17,000 patients whose blood pressure was carefully monitored. And you can see that in this stroke population, when systolic blood pressure dropped below 140, mortality increased. Let me say that again for you. When systolic blood pressure dropped below 140 in patients with an embolic stroke, mortality increased. We in anesthesia never aim for a systolic blood pressure of 140. So perhaps one of the lessons here is if you are concerned that a patient may have had or is at high risk for an intraoperative stroke, keep the blood pressure up, up, up. It may not prevent the embolus from causing the stroke, but it will reduce the probability of very bad outcome. So as far as we know, the vast majority of perioperative strokes are embolic, or at least have the same imaging and other characteristics as embolic strokes outside of the perioperative period. So in terms of management and improving outcome, I think one of the first steps is early nursing diagnosis. And we proposed in this detailed review of all of the stroke screening tools that are out there, that this simple tool be used. It takes maybe 30 or 45 seconds for someone to do. It's the fast face, arm, speech, and then time, face, hold an arm out with your eyes closed. We have added in, could anesthesia be influencing what you see, either magnifying the neurologic deficit, or the patient is so obtunded that it is hard to depend on this. And time is brain. You do not want to waste time. and therefore you want to get an early neurology consult. Many hospitals, including our own, now have a code stroke. This allows the nursing staff, if they think the patient may have had a stroke, to call a neurologist themselves, rather than calling the operating room, waiting till somebody from the surgical team can call them back to ask, can we call a neurologist? A code stroke authorizes the nursing staff to get an immediate neurology consult and a CT scan. If the patient has had a stroke, they should be moved to an ICU or a stroke monitoring unit. They need to be somewhere where their neurologic status and their cardiovascular status can be monitored. Arrhythmias are a surprisingly common cause of death in stroke. Aspirin is still recommended in stroke management, and most patients in the perioperative and the postoperative period will not have excessive life-threatening bleeding if given an aspirin. And while TPA is contraindicated postoperatively, mechanical thrombolysis is not and should always be considered. This can be done without heparinization, and our recommendation is that the evaluation of the patient should always include in the note that mechanical thrombolysis was considered and the reason that it was not undertaken. So, in summary, I think we and our surgical colleagues need to accept that this is a very real problem and it isn't totally rare and never happens. We need to tell patients the risks, particularly if they are at high risk. We absolutely need ongoing, better prospective data collection so we can understand the etiology and contributing factors. We need to understand the pathophysiology, especially that interaction of inflammatory changes between surgery and stroke that may allow us to come up with pharmacologic mechanisms of preventing or blocking that, and absolutely early diagnosis and treatment are crucial in stroke management. Thank you very much. I hope you have a very successful conference.